So, once again, I welcome you all and starting off with the case. So, we were notified on an incoming trauma patient, a 32-year-old male who came from a certain hospital. The mechanism of trauma was the Boda rider. He lost control and fell. The injuries sustained were chest abrasions. The signs: the patient presented with respiratory distress, chest pain, and the treatment given so far was oxygen. At this point, I would invite Ms. Shane to brief us about the ISBAR handover.
Good evening, team. I am Jane Nalunkuma and I'm an EMT. With me here is Mr. KM, a 32-year-old who is been referred from our district hospital. He's a Boda rider who was hit by a trailer 12 hours ago. Had a helmet on, didn't lose consciousness, all blood thinners, and was transported to our hospital by a bike. He presented with chest injury and respiratory distress on arrival. On my assessment, he was saturating at 70% on room air, gave 4 liters of oxygen via a nasal cannula, and is saturating at 94%. In transit, occasionally needing 16 liters of oxygen. He received 2 liters of NS, received antibiotics, cefazolin, and paracetamol 1 gram in the last 4 hours. I'm really sure he will benefit from advanced respiratory support and imaging. Any questions for me? Yes, any questions for me?
So, what's the patient's level of consciousness? Are they able to consistently breathe on their own? Can they hear you? Can you guys hear me?
Yes, we can hear you.
So at this point, there are a few questions in the audience, so I think Daniel will take care of that. But at this point, I would love to know whether, besides the respiratory distress, whether this patient is alert or semi-conscious, and if they're able to consistently breathe on their own. Besides oxygen, is there any other needs that you would like us to prepare in the hospital? And I'll prepare my team to just get ready, our trauma team, to be ready for the patient regarding the airway, the breathing, the circulation, ABCDE, as you prepare the patient to move to hospital. The other key thing I would like you to confirm is how far you're moving from the hospital to come to. How far are you from the scene to the hospital, and what other things you would like us to prepare as we prepare the team? So as the pre-hospital team, is there any uncontrolled hemorrhage or that's not an issue? Now that you've communicated, our team is going to be preparing but continue giving the patient the particular treatment you've started, particularly oxygen, as we prepare for you in the hospital, and aim to get here as fast as possible. But at the moment, I think we have potentially a breathing problem. Yeah.
Yes, our patient doesn't have any catastrophic bleeding around, apart from the bruises around the chest.
All right, so prepare to move. We shall let you get the patient moved to hospital as soon as possible, and then we shall prepare the team to do a primary survey once we've received the patient, and that will include the ABCDE and any other treatments that follow as we assess immediately. Yeah.
Okay, thank you.
Thank you so much, Dr. Priska, for your additions. So moving on with the primary, okay, before the primary survey, here is a video of how the patient presented at the department, at the emergency. So after this video, I would ask any volunteer to tell what they see in this video. And yes, so here's the video.
So you can post your answers on the chat, and we shall be able to follow as as Tripati moves on. So I've seen two answers. Someone says it's a pneumothorax, and the other screams out it's a pleo segment and pleo chest, evidenced by paradoxical movement. Tripati.
Okay, thank you so much for your active participation. So now that we have some submissions, I would like to invite the expert as she will share what her perspective of this presentation is and what she would want the participants to appreciate in this video. Dr. Priska, the floor is yours.
Thank you, Tithi. So from this video, we can appreciate, without even touching the patient, you can appreciate that on looking, there's bruises all over the chest with an obvious asymmetric, should I say asymmetric chest movement, particularly with the right sinking in each time the patient that tries to breathe. And that is often called a flail segment, where you have more than two ribs next to each other that are broken, and so they cannot sustain, they cannot expand properly during the usual way of breathing. And it's a real threat to the patient's ventilation. That's what I want us to take away. The other key thing is that the patient is breathing quite deeply. So clearly they're trying to compensate for maybe oxygen insufficiency, as we learned earlier that the saturation was 70% on room air, and the normal should be 94 and above. Our patient was at 70 and could come up once given. But even with that, they are still at imminent risk, and we need to get them to hospital where they can be given other advanced management as soon as possible. Yeah.
Thank you so much, Doctor, for mentioning the clinical points we need to appreciate here. So moving on to the primary survey. In airway, the patient is shouting and coughing. In breathing, we saw the patient was using accessory muscles. The respiratory rate was at 30 breaths per minute. We noted a 6 by 12 centimeter abrasion on the right side of the chest and paradoxical movement and reduced air entry on the right side of the chest. The left side was normal. The patient was saturating at 85% on 5 liters of oxygen by nasal cannula. A right-sided chest tube was placed, which resulted into frank blood collection in the underwater seal drain and with continuous drainage of frank blood. In circulation, thin radial pulse was noted. The blood pressure was 80/60 millimeters of mercury. The heart rate was at 110 beats per minute. We noted cold feet, and the capillary refill was greater than 5 seconds. In disability, the patient was confused with a GCS score of 14 out of 15. The pupils were equal and reactive to light. The glucose measured was 2.8 millimoles per liter. Exposure, there was no other traumatic injuries seen. A cervical collar and backboard was placed. In FAST, that is focused assessment with sonography in trauma, the findings were intermediate or they were not very clear due to the presence of subcutaneous emphysema, which limited the visibility. So at this point, I would invite a volunteer from the participants, maybe as briefly as they can, they would highlight the important findings which we should be concerned about in this patient.
Jessica, unmuted. Jessica Nakubulwa, please, could you carry on and speak? No problem. Please post the findings you have on the chat. We shall read them out loud. Tiffy, you can carry on.
Okay, so as the submissions are coming in, at this point, we have a poll that would be sent in the group chat. Dr. Daniel, maybe you could reverbalize about the poll question.
Okay, so there's a poll question that is running in the chat, but I'll just re-echo it, and there you go. Based on the primary survey findings, what are these patients' life-threatening conditions? You could just pick one, and it's just in a few seconds, everyone will be able to give us. Yeah. When this hits 1 minute, we shall be moving on to the next slide. Great. I love the turnout of the voters, of the answers, which is fancy enough. Okay. So in 5, 4, 3, 2, 1, end of poll. Tithi, we can carry on.
Okay. So now it's time for the audience. In the chat, you can mention if there is any other additional information you would like to know about the patient, and we will answer those. Please feel free to submit your thoughts. They're most welcome.
Yes, Helen, Jocelyn, you've unmuted. So any additional thoughts so far? So there is a question here. It's part of any additional. Is the GCS of 14 out of 15 considered low?
Okay, thank you for the question. So maybe I would ask the expert to come and share her opinion on this question. What would be the likely answer? Dr. Priska?
That's a very good question, Samuel. So GCS of 14 out of 15 is definitely low. The normal is 15, sorry, but there are grades within the severity of how low this GCS is, and 13, 14 normally considered, actually 14 is considered confusion, which is mild head injury most times if you're talking about such diagnosis. And anything that goes 8 and below is severely low GCS, and we would be worried about this patient even more. But at this point where he's at 14, you would worry about, I think Tithi will tell us later what they did, but you would worry about some of the differentials that some of you have mentioned on the screen and in the poll. I don't want to preempt the discussion, but yeah, hypoglycemia.
Thank you so much, Doctor, for guiding us here. So I hope I can move to the next slide, which again calls upon expert. Maybe she can give us what she thinks about the patient at this juncture. And we are also curious to know what, according to her, would be the ideal approach to the patient during and after this primary survey.
Thank you, Tithi. So going back to what they've presented us, the patient is shouting and coughing, telling us that we are going according to the ABCDE. Sorry about the noise in my background. However, currently I would start with looking for any exsanguinating hemorrhage in my primary survey. And I'm not sure if they found any of that, but that would be my first step, as it's been showed that the patient will die faster from that exsanguinating hemorrhage before we even go to the ABCs. So after I've ruled that out, I would, so airway is clear. B, I would do inspection, palpation, percussion, and auscultation, IPPA, and rule out any, based on our findings from the image, the video. The patient has a flail segment, they have low saturation, they are likely, they are also tachypnic, so I'm worried about oxygenation here, respiratory distress, respiratory failure to some extent. And I would give this patient high flow oxygen by mask, not by nasal prongs. If I have the mask, I would start with that 15 liters until they get to hospital, or while they're in hospital and if I can intubate at this point, I would also intubate the patient. But caution, my patient's GCS is still fairly okay. So maybe is a bargain there between rushing into intubation and giving them adequate oxygenation and managing with non-invasive positive airway pressure, PPV, to help keep out that flail segment, but while also giving them some painkillers to allow them to breathe in better. So that will be my approach to the B. And in the C, this patient definitely looks like they're in, it could be hypovolemic shock given what they got from the chest tube insertion. So I'm worried about a hemopneumo or even a plain pneumo or a pulmonary contusion given that abrasion on the bad abrasion on the skin on the chest. So again, I would solve this with some judicious fluid management initially, maybe 500 mils as we continue managing the A and B, and treat the hypoglycemia. That 2.8 is definitely below for a young man like that. 3.3 would be my cutoff. So I would give them some bolus of 25% dextrose and see whether their level of consciousness would come up, and they probably would even breathe a little better. And I would look for any other injuries through the exposure and monitor my patient continuously on a cardiac monitor. That would be my initial approach in this patient. And I'm doing this with a team simultaneously, not one by one, so that this patient is, we come to a conclusion as soon as possible. Thank you.
Thank you so much, Doctor, for your reflection on to this case. So as we move further, we are going to see the ED intervention which was given. And regarding if there is any life-threatening hemorrhages, in exposure, we noted that there was no any other traumatic injury seen in the patient. So, and the other aspects of the management plan, we will see what was done for this patient soon. So moving on, we have another video, and I would really encourage the participants to submit what they think is this intervention, and what they can interpret from this video. All submissions are most welcome.
Yeah, feel free to type your answers down at the chat. Yeah. Great, Tithi, we can carry on.
Okay, so we would also want to know what our expert thinks about this investigation. Dr. Priska, we are waiting for your interpretation.
Okay, from this video, which is focusing on the right upper quadrant, it's one view, so it's not the best if I'm to consider it as a first, but generally speaking, it looks like we have a very small or collapsing IVC telling me that my patient is definitely hypovolemic. I can also sneak at the heart a little, and it's, pumping very fast, but I can't see any more information like fluid around the heart or fluid above the diaphragm nicely here. So I would appreciate another view if I had a chance, 2 other views, 3. So I'm basically thinking hypovolemic shock based on the collapsing IVC, where the 2 are call it a kissing IVC, really. Yeah.
Thank you so much, Doctor, for mentioning the important things that we have to note here. And we only have one view for this patient. And yes, I would just re-mention the fact that this is a video of an collapsing IVC. And yeah, so I hope all of us have appreciated how it looks like. So now this is our ED intervention in summary. So the neck cervical collar was placed, and the patient was put on high flow of oxygen through a non-rebreather mask at 15 liters of oxygen per minute. 2 IV lines were placed in the patient, samples were collected, Blood samples were collected, and 20 ml per kg of normal saline was administered to this patient. A right-sided chest tube, which was placed earlier, had collected 1 liter of blood in the first 30 minutes, and it was an underwater seal drain. For pain management, paracetamol 1 gram, fentanyl 100 microgram, and a regional chest block was administered. Chest X-ray was taken before and after the placement of chest tube. The patient was eventually planned for a cervical spine X-ray and a brain CT scan. And we were waiting for a consult from the general surgery, or in specific, it was the cardiothoracic surgery. So let's first have few questions maybe from the audience in the chat before we call upon our expert once again. If there is anything the participants have appreciated or would want to know more, your submissions are most welcome. Okay. As we wait for more submissions, I guess at this point we have another poll question. Dr. Daniel, could you please take over from here?
Yes, please. The poll is coming up in a bit. So members, prepare as you bring your submissions. I know the expert is also preparing her summary in initial thoughts in as few words as possible. Yes, so Hilary, the poll should be up now. In the interim, Dr. Priska, you can give us your initial thoughts. Let's continue. We are having just a technical glitch that is being fixed right now. Dr. Priska, please come and share your thoughts.
So almost similar to my initial thoughts. At this point, I'm worried about the patient being in hypovolemic shock. They've lost a whole liter of fluid from the chest. They are also, and that could probably confound the pulse oximetry, but I see that this was addressed using the volume of 20 mils per kilogram. They are also they were also hypoxic. So, but this has been helped by giving the patient analgesia with a regional block. I see fentanyl. I feel like this patient was in a very good setting. They received a lot of analgesia, and that should be able to help the patient breathe better. I would worry about the 20 mils per kg boluses in a patient. So I would probably start small, because 20 mils per kg in a patient who is 70 kilograms is 1.4 liters at the start, and that's quite a lot. So I would start with 500 mils and check my patient's vital signs, and if they're improving, or if they're not improving, give another 500 mils bolus. So I would do it intermittently and not all the 20 mils per kg at once. The other key thing is I think I missed this, but I think their SpO2 improved and they're being managed appropriately in that regard. I wonder why we did not give any sugar to this patient, because their GCS was 14, and they definitely have a low level of glucose. So I would give this patient let me see, we normally say 25 grams of dextrose, so 25% of dextrose. Get the 50 ml bottle and do half of that and add another 50 mils and give them 25% grams of dextrose IV bolus to help improve that. Without seeing any other views of the POCUS, I would not delay. I would not assume. So I like that the team consulted or called out to the general surgeon and cardiothoracic surgeon. Clearly, they're in a very nice big hospital, and I would love to hear what happened after that. I would also give TXA in this patient because clearly they lost, they're losing the 1 liter. That means they might continue to bleed a little more. So tranexamic acid, 1 gram at the start, as long as it's within 3 hours from the time of injury, we can give that tranexamic acid and keep the patient warm so that we prevent any coagulopathy as we continue giving them fluids. And these fluids should be warm, so hoping that they were actually warmed fluids. And if we have blood, preferably give blood. Yeah.
Thank you so much, Doctor. So yes, I hope all of us have appreciated the key things which could have been additionally done in this patient. And maybe I would also invite our mentor, Dr. Doreen, to give her thoughts about this patient, the intervention that had been done, and also maybe talk about the recommendations which were given by our expert.
Thank you, Tiffy. Thank you, Dr. Priska. Colleagues online, thank you for taking part in the poll. As the presenter has stated, this is a trauma patient, and we had 2 major areas that were life-threatening. One in the breathing, but also in the disability, where his GCS is low and blood sugar is low. The case has been described to you. This is a patient who was in severe respiratory distress, a patient who was also in shock, so a circulatory problem as well. The expert has been able to take us through step-by-step resuscitation. We have followed the systematic approach of the primary survey. So now we just have to take it from there and see how the patient progressed. Just to remind you, the role of the primary survey is to identify life-threatening conditions and manage them. Before you move on, you have to make sure you reassess to ensure that what you have managed has had a change in the patient's clinical picture. This is a patient who needed a multidisciplinary approach. They definitely needed input from CTS, needed input from neuro, needed input from general surgery, they needed input even from critical care because it looked like this patient was deteriorating very fast. And like Dr. Priska has mentioned, this is the kind of patient that you would consider to have intubated, put on a mechanical ventilator and taken into the ICU. So this is a patient that needed a multidisciplinary approach. But let's take it from here, Tiffy, and we move forward.
Okay. Thank you so much, Doctor, for your guidance and the reflection on the case. So moving forward, let's quickly go through the sample history. Under signs and symptoms, the patient had sharp right-sided chest pain. No known allergies were reported. In medication, 5 liters of oxygen was given. PCM, dexamethasone, cefazolin was given pre-arrival. There was no significant past medical history in the patient. Last meal was taken 24 hours ago, and the events that led to this presentation was that the Boda rider was knocked by a trailer. So this is a chest X-ray which was done before chest tube insertion. So I would appreciate if the audience would submit their interpretation, what they can see here in the chats. And I would want more submissions to come on chats. Let's be more interactive. As I call again our expert, Dr. Priska, to share with us what we need to hear.
Thank you, Tithi. So based on the image that I see here, this is a chest X-ray for the patient in question. It's not the best view because I can't see the costochondral junctions nicely. However, with what I have, there is obviously rib fractures, and I also can't see the top part of the chest, but I think this is like rib 4. Let me see, about rib 4. An obvious fracture there because there is discontinuity. Yeah, someone is nicely using the pointer. And there is probably other unseen fractures if we had a better view and if we had the live image and there is opacity on the right side still, which would make me think about pleural effusion, but I can't appreciate a nice meniscus. So probably a lung contusion would come first, top of my list. And on this side, on the left, it's grossly, it looks much better than this side, than the right side. And I would appreciate a better image. Yeah. So lung contusion, rib fractures, and likely hemothorax.
Thank you so much, Doctor, for highlighting the findings here. And moving on to the secondary survey, in the musculoskeletal system, there were no deformities or swellings noted in the upper and lower limb. No bleeding from any other sites were seen. Skin was intact outside the chest wall. The log roll was performed, and no deformity, swelling, or step down of the spine bone was seen. Reassessment was conducted after 1 hour. The patient was seen to be improving. Respiratory rate was 24 breaths per minute. The blood pressure had stabilized to 110/90 millimeters of mercury. Heart rate was 89 beats per minute. The patient was now saturating at 95% on a non-rebreather mask at 15 liters of oxygen per minute. After 2 hours, the patient was reassessed, and the patient now developed worsening cough and shortness of breath with chest pain. The respiratory rate now was 32 breaths per minute. The blood pressure was 80/60 millimeters of mercury. The SpO2 was 82% on non-rebreather mask at high flow of oxygen at 15 liters per minute. And the heart rate was 120 beats per minute. There were cross crepitation heard on the right side of the lung. In the subsequent ED course, we noted that the chest tube had already drained 1.8 liters of blood. Since the patient was deteriorating, the patient was bagged using a bag valve mask. IV noradrenaline was given, which resulted in expanding volume, which was noted on IVC ultrasound. 3 units of whole blood was transfused. Following this, endotracheal intubation was done for mechanical ventilation. However, post-intubation, the patient arrested. CPR was done, and it was terminated after 20 minutes without a return of spontaneous circulation. So at this point, I would first encourage the audience to, in the chats, they can mention what could be the possible differentials in this patient. And then later, I would also request our expert, Dr. Priska, to share her opinion on the top differentials she would consider at this point, and what would be the proposed management plan.
Yes, keep the answers coming. We also have a team that is on the chat responding to the various questions that are upcoming. If there are any glaring questions that come, I will always respond to them. For instance, Deborah asks, what are crepitations? So something like that, Deborah. I'm trying to be as loud as possible, but this is what you hear when the lungs are swollen inside and they're having some fluid surrounding those alveoli. So whenever air is entering in and out of the lungs, you hear a certain sound like respiration, like a vera. Thank you very much. On to the expert.
So at this point, the top differentials I am considering, very interesting turn of events here, but the patient clearly deteriorated later into shock, and worsening hypoxia, and eventually was intubated. And I'm just recapping this for the flow, and eventually ended up with a cardiac arrest post-intubation. So the likely causes of a traumatic cardiac arrest are usually what we say, the two T's and the two H's. So hypoxia, hypovolemia. As we can see, our patient ended up having both in terms of our vital signs, and tension pneumothorax and cardiac tamponade are the other two common causes of traumatic cardiac arrest. But based on our features here, the patient after intubation, they could have developed a tension pneumothorax. I would have loved to know whether there were other signs, but I know that in the heat of the moment, it's sometimes the things that are skipped. So whether there was an elevated JVP peri-arrest, or how the pulses, basically going back to the ABCDE as Dr. Doreen highlighted, assess, manage, reassess, and if anything changes, we go back to the ABCDE fully. So I would have loved to know if there was any key change in there. The other key thing I want to highlight is, so those four, the two H's and two T's and my top differentials in there. However, I'm also thinking the lung contusion could have gotten worse, but it's less likely to cause a quick cardiac arrest like that. So maybe they developed a tension post-intubation, given that they had rib fractures, and then we gave them some positive pressure and after intubation or before we intubated through the BVM technique. Yeah, that's what I think. And the proposed management plan and disposition for this patient, if they had not gone that direction, would have been, I definitely would have gone back to reevaluating with the POCUS, the point of care, the EFAST or point of care ultrasound, which would have looked in all the possible spaces, looked for current pneumothorax by loss of lung sliding, and also showed me if there was any fluid in the abdomen, because the patient definitely was in shock, and it could be pneumo or abdominal fluid that was missed. Since they have rib fractures, it could be the liver involved over there. It could be ruptured and they could bleed into their abdomen. their level of consciousness did not go down massively, so I don't think it was in the brain, and I don't think it's a cardiac tamponade, but likely. So I would, they did the best, which was to transfuse. I would have done that. I would have done the focus like I've highlighted to guide any other specialists involved, and maybe preferably have this patient could have, I don't know if there were any signs of in the abdomen, but if they were, we would have gone into an X-lab just in case. I didn't see that, so I would have appreciated more signs there. Yeah, I think that's it.
Okay, thank you so much, doctor, for sharing with us your opinion and the proposed management plan. So let's move forward and discuss the key issues that was in this patient. Number one, as mentioned already, that the patient had a trauma, which was with a high impact mechanism, but it didn't involve the head and spine of the patient. The patient was in shock due to excessive blood loss. So the patient presented with tachycardia, hypotension, altered GCS. However, without obvious blood loss, and we would have to consider internal bleeding at this point, which the patient had. Then, yes, the patient also had a blunt chest trauma, hemothorax, and we saw a flail segment on the right side of the chest. And the patient was put on, another issue was that the chest tube was placed in the patient, and there was possibly a re-expansion syndrome that happened in the patient. And also the patient was hypoglycemic. So for the pearls and pitfalls, I would once again invite the expert to share what could have been done, or what we would have kept in mind that wouldn't have resulted in such a scenario. Dr. Priska, we are waiting for your opinion and thoughts.
So thank you again. So for the pearls and pitfalls, I feel like this patient was approached very well, but a few things that I would love to highlight were the besides the usual ABCDE approach, pre-hospital, the pearls are, when in doubt, transport to the nearest health facility as soon as possible, which I think was well done, I imagine, based on the case, and emphasis on the assess, manage, reevaluate. I note that ultrasound initially was hard, given that the patient has had a lot of subcutaneous emphysema and we got only one view. But while in hospital, we do the best to get most of our investigations done. And I think it would have helped to know a little more around that, so that we guide with the disposition even faster. The other key thing is be aware of a worsening pneumothorax, especially for patients that are already showing signs of blunt chest trauma, rib fractures, anything that increases air in the chest, positive pressure ventilation, so bagging a patient might potentially lead a patient into a tension pneumothorax. So beware of that and make sure that you have a functioning chest tube before you take the patient through that. Beware of the confounding from hypovolemia as a cause of hypoxia, as a loss of signal on your pulse oximeter. It's very likely that your patient isn't picking up peripheral pulses nicely because they're cold. So keep the patient warm, give them adequate fluid, and if you had 70, it could come up later. The other last thing is volume resuscitation is not cautious, but let me use the word judicious. Like, you do it in a phased manner, because in blunt trauma, if you give fluids, your target map in blunt trauma is preferably hypotensive resuscitation. You might dislodge a clot. So every time you give them, you give a patient with blunt trauma, like our patient here, if it's in the abdomen or the chest, you're going to dislodge the clot and you lead to a further hypotension. So it's possible that's what happened, leading to further deterioration. So our target is to make sure that they are just they get a systolic BP of maybe 80, 90, as long as they don't have altered mental status with potential head injury. We can aim for low, normal systolic, with just improvement of vital signs, but not to the best, not to the normal. Sorry about that term. The last thing is keeping the patient warm. A cold patient who is in shock will continue bleeding. You drive coagulopathy. So keep that patient warm, use warm fluids, make sure the blood is warmed up, not in a microwave, but, just thaw that blood so that you give it, you don't give them cold blood. And team membership, leadership must be very good, because even smaller teams of 3, as long as they do this every day and practice and have good leadership and teamwork, they're able to save a patient. My final thought is that it's very important to take note of the things that could deteriorate. For example, failed airway, equipment failure. So our tube could have been blocked. I'm not sure about that. I'm just giving it as an example. Failure to control hemorrhage. So think about all these things. We could do everything right, but all these things could fail at a certain time too. So be aware of that and keep monitoring your patient and calling the right people. It's a multidisciplinary approach. Yeah, thank you very much.
Thank you very much, Dr. Priska, for those insightful pearls and pitfalls that you have highlighted. And for the students, I would interest you in further going to read about what Dr. Priska has hinted in local language, the lethal triad in trauma. So yeah, read about that. And also, one of the things I need you to read about is massive hemothorax. And this patient somewhat fitted the definition, where we know that they drain, when you drain 1,000 to 1,500 mils, do not be so excited. Know that there's something that is wrong in that chest, potentially an active bleeder, or rather draining 200 to 300 mils in 2 to 4 hours should also be 200 to 300 per hour in 2 to 3 hours is a bad indicator as well, that you would also consider to define as a pneumothorax. So at this point, Tithi, you have 3 minutes to actually try and run through the slides that you have left, trying to highlight about the condition in play. Thank you.
Thank you so much, Doctor, for the clinical points which have been mentioned, and I hope we have appreciated them. So due to lack of time, I would give you guys a hint of a possible complication of chest tube placement, which is a re-expansion pulmonary edema. So it is a very rare but potentially fatal complication following a rapid re-expansion of a collapsed lump. And if it's greater than 3 days of a collapse, it is more likely to happen. It's more common in young and healthy adults. Due to lack of time, I'll just give you guys a brief about this condition, and I would highly encourage you to go back and research more about this. It is called re-expansion pulmonary edema. So the mechanism, or what could contribute to this this disorder, could be a rapid re-expansion or prolonged lung collapse or hypoxia induced inflammation. The risk factors for this phenomenon would be a lung collapse, a prolonged lung collapse for more than 72 hours, then a rapid re-expansion with a large volume chest tube drainage, young age, pre-existing disease or hypoxia, or if there has been a traumatic lung injury or lung contusion. The symptoms would develop 1 to 24 hours post-drainage. It is usually on the side of the drainage, and the symptoms would be sudden dyspnea, hypoxia, cough, tachypnea, tachycardia, and hypotension. What we need to care if we are able to foresee a re-expansion pulmonary edema is that we have supportive care and preventive care. What we can do to prevent is that we would have to drain slowly, which would be less than 1.5 liters at a time, monitor closely, use a smaller chest tube, and delay a full re-expansion if the lung has been collapsed. Supportive care would be oxygen therapy, mechanical ventilation, hemodynamic support, to mention a few. So at this point, I would also invite our mentor, Dr. Doreen, to share some key learning points that we can take away from this case as I submit. Dr. Doreen?
So thank you, Tiffy, very much. Just because we're running out of time, I'm going to be very brief. So that the takeaway is the primary survey. Make sure you ensure that you follow your primary survey. This is a very rare occurrence, but like for any other emergency, the approach is the same, the ABCDE approach. This is one of the conditions whereby you should, as much as possible, prevention is better than cure. Do not drain your hemothorax or your pleural fluid rapidly. So this is what happens when you have a hemothorax or a pleural effusion. It is within your pleural cavity. Then when you drain it so rapidly, your lung expands very fast because initially the lung was collapsed. As it starts to expand, your blood vessels now become very permeable and fluid now accumulates into the alveoli. And that causes a pulmonary edema. How it presents, patient deteriorates, they start to cough, they become tachycardic, they get a wet chest. So you listen to the crackles bilaterally. How you manage it, you need supportive therapy, oxygenation. They usually do well with positive pressure ventilation, especially your BiPAP and your CPAP. If you can intubate, that would also be good. But identification is very, very important. And it is an emergency, so the same approach should apply, which is your primary survey, which is your A, B, C, D, and E. Thank you very much.
Thank you very much, Dr. Doreen. And I know we have emojis and etc. You can just give us a round of applause for the beautiful case, well presented. And thanks to Jen, Tiffy, Dr. Priska, and the mentor to Tiffy, Dr. Doreen, for this wonderful case. Surely I'm not going to repeat much that has already been mentioned, but just to encourage you to join these trainings of ATLS, ITLS, where you will learn pre-hospital care and in-hospital care, and having these 5 things in your hand, A, B, C, D, E, the primary survey and secondary survey, will just be a piece of cake for you to eat in any birthday. Thank you very much for your turn up. It was really lovely to see close to 200 people in this. Tell a friend to tell a friend that knowledge is power, and there's only any given source that you will get it freely and cheaply with loving people, and that is the Clinical Pathological Cases series, CPC. I would love to say good night to all of you. Oh, but before you log out, the poll questions, I'm just trying to pull them up right now. So yes, so we shall just go to the first one. So it ended, and surely 69% of the people passed. So 29 out of the 98 said the patient had respiratory distress with a possible hemonemo and they were in shock. This was according to primary survey. The second one, right? Again, 89% of the people passed, and they said that it was a hemothorax that presents with a dull percussion note. Remember to use your stethoscope wisely, and when you're next to the emergency physicians and anesthesiologists, focus is your lovely thing that you will always use. Allow me to say good night and good evening to everyone, and we shall see you in the next series that we shall pursue. Thank you very much.
Thank you.
Thank you for the presentation.